Welcome to those of you who have joined us already. We're so thankful that you have chosen to join us for our inaugural Grand Rounds this evening. My name is Lauren Rivard, and I'm a perinatal consultant with the Champlain Maternal Newborn Regional Program in Kingston, Ontario. I'd like to start the evening with a land acknowledgement. So we recognize that CMNRP's members and stakeholders are located on traditional Indigenous territories across Ontario. The CMNRP offices are located in Ottawa and Kingston, which are built on the unceded territories of the Algonquin, Anishinaabe, and the Haudenosaunee peoples. The peoples of the Anishinaabe and Haudenosaunee nations have lived on this territory for millennia, and we honor them and this land. I'm going to invite you to reflect on the land that you are on, thinking of who the traditional keepers are of the land and what the treaty relationship is, or if you're living on unceded territory. We want to take some time to recognize that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We acknowledge that there is a lot of work to do to honor Indigenous women's and families' pregnancy journeys and to bring reconciliation to healthcare in Ontario. We acknowledge our role in collaborating with Indigenous peoples to raise awareness of Indigenous peoples' challenges in the perinatal period and pledge to contribute to ensuring clinical perinatal care is respectful and safe. This is also a time to reflect on and acknowledge the harms and mistakes of the past and to consider how we can, each in our own way, move forward in a spirit of reconciliation and collaboration. We are truly grateful for the opportunity to live, learn, work, and play on this land. We remain committed to and acknowledge responsibility for building and improving relationships with First Nations, Inuit, and Métis people. I'll now provide a brief introduction to CMNRP for those of you who may not be familiar with us. CMNRP, the Champlain Maternal Newborn Regional Program, is a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. We do this across the region by working with our partners to ensure high quality integrated services and care occur at the right time, at the right place, by the right provider along the continuum of care from pregnancy through the postnatal period. The extended CMNRP network includes many of you, and more broadly, we have representation or representatives from hospitals, midwifery practice groups, public health units, community health centers, academic institutions, a birth center, and other community agencies that provide perinatal and newborn services. I am now honored to introduce our speaker for this evening, Dr. Anna Werlang. Dr. Werlang is a maternal fetal medicine specialist at the University of Ottawa and currently has a role as an assistant professor at the Ottawa Hospital in the Department of Obstetrics, Gynecology, and Newborn Care, the Division of Maternal Fetal Medicine. She completed her master's in science in healthcare quality and improvement at Queen's University in 2021, and she currently co-chairs the OB-GYN Quality Assurance Committee and is engaged in various quality initiatives and innovative technology implementation at the Ottawa Hospital, focusing on improving outcomes in pregnancy and postpartum. Her research interests include preeclampsia prevention, postpartum cardiovascular health, maternal sepsis, and obstetric ultrasound quality improvement. So without further ado, I'm going to hand it over to Dr. Werlang to begin our webinar on PLGF.
Thank you, Lauren. Can you just confirm you can see my screen?
Yes.
And thank you so much for the kind introduction, and it's a pleasure. And I'm actually honored to be here to be kicking off the first of many grand rounds to come from CMNRP. So thank you for inviting me. So today I'm going to talk to you about PLGF. The objectives for this talk is to understand the biological role of PLGF and its relevance in the pathophysiology of preeclampsia and placental dysfunction. We will learn to interpret PLGF results in the clinical context and apply PLGF testing to clinical decision-making, particularly for risk stratification of preeclampsia in the second and third trimesters, increased surveillance and management planning. So I just wanted to touch base on pathophysiology. Let's start by going over the pathophysiology of preeclampsia. On the left side of the screen, you can see that normal placental development, that around 20 weeks of gestation, this process of spiral artery remodeling is actually complete. And if the spiral arteries are remodeled and it goes well, there is a point that vascular resistance is very low because these arteries are really wide, given the deep trophoblast invasion. Normal placentation is expressed by large amounts of angiogenic markers in the maternal bloodstream, such as high amounts of PLGF being released, which promotes healthy angiogenesis. On the other hand, as you see on the right side, if the remodeling of the spiral arteries goes wrong, the arteries become quite narrow and stiff with increased resistance flow that will actually manifest clinically as poor placental function. And on the maternal side, you'd see preeclampsia. On the baby side, you'd see fetal growth restriction. Impaired trophoblastic function leads to reduced production and release of angiogenic markers such as PLGF, contributing to poor vascular development. On the right side, if you have here normal placental function, you see that there is a balance between angiogenic markers if you have normal placentation and normal placental function. But when you have placental insufficiency due to the poor remodeling of the spiral arteries, it will lead to hypoxia, translating to low release of PLGF and upregulation of other markers such as binding S-FLT1, which is released into the maternal circulation in excess. So we'll have a rise of S-FLT1 and a decrease in PLGF, which will give you differences in the S-FLT-PLGF1 ratio. Clinically, pathophysiological shift is reflected in low levels of PLGF and high S-FLT-PLGF ratio, which becomes a valuable biomarker for diagnosing and risk stratifying placental dysfunction. This graph here, I wanted to share with you in blue the normal pregnancy levels of PLGF, how it happens since the first trimester all the way to term. So you see a very slow rise of PLGF peaking between 26 and 32 weeks gestation and a slow decrease of PLGF towards term. And if you have a placental that is dysfunctional, like in the case of preeclampsia, you see represented in the traced yellow line here how it would work for the levels of PLGF. So the rise won't be the same. It would be a very blunt, slow rise of the PLGF that doesn't reach normal levels when it should peak, and then also a slow decrease and leading to lower availability of PLGF in the maternal bloodstream in the second and third trimesters. In fact, as I said, PLGF can be detected as early as 11 weeks gestation, and it is used for universal screen of preeclampsia. We usually, like in Ontario, or if we don't do it, SOGC still doesn't recommend universal screening for preeclampsia with the NT scan, although there's good evidence for screening for preeclampsia because we don't have availability and equitable access to PLGF in every center, but we're working towards it. I just wanted to share how the preeclampsia calculator, Fetal Medicine Foundation preeclampsia calculator works. And you can see here in this publication that if you add up to the maternal demographics, that is the first column on the right. If you keep adding up the mean arterial pressure, uterine artery PI, and then the biomarkers such as PLGF, you increase gradually in a direct correlation the prediction and the detection rate of preeclampsia, early onset in red, late onset preeclampsia in blue, reaching up to 90% of detection rate for early onset preeclampsia if you have all the markers together, increasing the performance of the calculator. And the same works in the lower grade for late onset preeclampsia, and doesn't perform as well for preeclampsia after 37 weeks, as we know. And I just wanted to bring this as a case of curiosity because we know that PLGF can be measured early in the first trimester, and it can be used for that purpose and performs really well in predicting preeclampsia, but that is not the objective for today. Today, we will focus on the role of PLGF for second and third trimester preeclampsia detection and risk stratification. In the second and third trimesters, the negative predictive value of PLGF is a powerful tool to rule out preeclampsia as a single marker or when used in conjunction with the S-FLT, generating the PLGF S-FLT ratio. So this is what our evidence say. We're going to dig a little bit deeper into what is out there about PLGF for preeclampsia screening. So the first trial that actually talked about PLGF as a powerful tool to screen for preeclampsia was called the Pelican trial, published in 2013. This was a non-blinded prospective multicenter study that looked at the diagnostic accuracy of low PLGF, less than the fifth centile for gestational age, in women presenting with suspected preeclampsia between 20 and 35 weeks, and then the secondary analysis looking at it up to 41 weeks of gestation. The primary outcome was delivery for confirmed preeclampsia within 14 days of PLGF testing. In this cohort, 55% of women developed confirmed preeclampsia. As you see on the red box here, in 287 women before 35 weeks gestation, low PLGF less than the fifth centile had a sensitivity of 96% and a negative predictive value of 98% for preeclampsia developing within the next 14 days. The sensitivity and the specificity and the negative predictive value of PLGF falls with gestational age, as you can see, a difference when tested between 35 to 36 weeks, as we saw that it physiologically does too. So because of earlier gestation of preeclampsia onset is associated with a greater maternal and perinatal risks, and the difference in PLGF concentrations between normal and preeclamptic women pregnancies is the most marked before 35 weeks, this trial showed us that PLGF has the potential to aid the diagnosis of hypertensive disorders of pregnancy at gestations that are critical to clinical outcome. Additionally, we also saw in the Pelican trial that the sensitivity of PLGF alone to predict PIH or preeclampsia within 14 days was 87%, as you see the red line here on the figure A. It was much higher than any other isolated parameter that we usually check with the PIH blood work, like blood pressure, like urate, LFTs, and the dipstick proteinuria. These are the other lines that you see here. The performance of PLGF alone was much superior than all the other isolated parameters. And when putting them together, as you can see on B, shows that the power of PLGF to predict preeclampsia in isolation, which is the red line, or in conjunction with blood pressure and urate and LT, and in adding up to all those parameters, still performs as like the same or better than these parameters. So the Pelican trial shows us that the power of PLGF to predict disease when it will happen based on PLGF alone and how it adds up to the PIH blood work is a reliable stratification tool. It showed us more actually. Here on this table, you see that the Pelican trial not only showed when preeclampsia is going to develop, but also correlated really well for time with time to delivery, depending on PLGF level. So the red bars are the very low PLGF levels. The yellow ones are intermediate, and the green ones correspond to normal PLGF. Here we can appreciate that the median time to delivery, stratified by PLGF concentration for all participants, and also just looking at the preeclampsia cohort, it was very reassuring to see that normal PLGF patients actually delivered way later, like weeks and weeks later after PLGF testing, meaning that these patients really didn't develop preeclampsia within the very first 2 weeks of testing, regardless the gestational age that they were tested and regardless the diagnosis of PIH. This shows the power of prediction for imminent delivery when you look at the red bars and you see that on the 14 line mark here, the 14 days after PLGF testing, most of women who were tested with very low PLGF deliver within this time frame, which tells us the power of prediction not only to diagnose disease, but also to infer or to predict when delivery will happen. A little later in 2018, there was the PER trial. So PER Ireland was a clinical trial, a multi-center clinical trial that was done in 11 maternity centers in the UK. As the assessment just based on hypertension and dipstick proteinuria may result in significant false positive and negative diagnosis due to low specificity and increased morbidity or unnecessary interventions, the primary objective of the PER trial was to determine if the addition of PLGF to baseline current clinical assessment of women with suspected preterm PIH was beneficial in precisely predicting preeclampsia and decreasing maternal morbidity. The primary outcome of the PAIR trial was time from presentation with preeclampsia to when preeclampsia was actually diagnosed. This was the design of the study, which was pretty simple. So women presenting with suspected preeclampsia would be randomized into one arm using PLGF, and that was revealed, like the results were revealed to the physicians, and they would follow a color-coded algorithm that I'll show on the next slide. And the other non-PLGF arm, like patients would still have PLGF, but that would be blinded or concealed to the physicians, and they will follow the guidelines according to NICE guidelines on hypertension and pregnancy. And the results were compared outcomes from the concealed with the usual management to a revealed PLGF testing group that were managed by the algorithm proposed based on PLGF level and also blood pressure levels at presentation to triage. So the results of the trial were published on the Lancet, and they revealed that when physicians had PLGF levels revealed to them, they found that the availability of PLGF test results in triage substantially and significantly reduced the time to clinical confirmation of preeclampsia by 2 days, as you can see here on the top box. And interestingly enough, even for severe preeclampsia, which seems to be something quite bread and butter for us obstetricians to detect in triage when a patient has all the severe symptoms and the very high level blood pressures, having PLGF still decreased the number of days to detect and to diagnose preeclampsia in triage. There were no differences in gestational age at delivery based on PLGF alone, meaning that they will still deliver based on clinical findings. However, where PLGF was implemented, they found a lower incidence of maternal adverse outcomes consistent with adoption of targeted enhanced surveillance as recommended in the clinical managed color-coded algorithm that I just showed you for clinicians. A reduction of about 2 days in diagnosing preterm preeclampsia is very important for decision making, including the place and frequency of management, avoidance of severe morbidity, allowing for temporization by administration of steroids for lung maturity, and planning the place and timing of delivery. The PAIR trial shows us that the ability to diagnose preeclampsia more rapidly enables targeted, individualized management and benefit of appropriately reassuring patients who do not need intensive investigations with a normal PLGF by minimizing excessive use of health services for those at lower risk within this acute period. So we'll pause here now a bit to check out this clinical case. Let's say you have a 24-year-old G1 P0, 25 weeks that presents to your OB triage at a level 1 center. She's known for chronic hypertension, poorly controlled. There's not much info prior to antenatal care. On her first antenatal visit, you know that she already had a baseline proteinuria in the first trimester, and her blood pressure on her first visit was 180 over 100. She arrives to triage with a blood pressure of 200 over 100, but asymptomatic. A fetal heart auscultation is normal. You don't have ultrasound available at this time to check for growth and Dopplers, and you request the PIH blood work. Everything comes back normal except for the PCR of 289. I think at this point, you ask yourself, is this superimposed preeclampsia she's developing, or is it just poorly optimized chronic hypertension that needs more medication and maybe she will be stable, we can send her home? But if it is preeclampsia, should I already give her steroids? And if it is preeclampsia, are we talking about delivery anytime soon? So before I answer to these questions, I just wanted to take a look at into some evidence to show you the power of prediction of PLGF for ruling out or ruling in disease in these cases. In this study published on AJOG, they corroborate the findings that in women with suspected preeclampsia less than 35 weeks gestation, a low PLGF was correlated strongly with preterm delivery independent of a diagnosis of PIH or at the gestational age at presentation, whereas a normal PLGF was associated with pregnancy prolongation, even in patients who ultimately had a final diagnosis of preeclampsia. As you can see on the red box here, the sensitivity and the negative predictive value for preeclampsia developing within 14 days and 7 days of testing are quite high at 90%. And when we look at delivery within 2 weeks or 1 week after testing for patients with low PLGF, the sensitivity and the negative predictive value were quite high as well. So that's quite reassuring. When you look at time of delivery in these graphs, we see that PLGF is a strong predictor of preterm birth, regardless of the diagnosis. On the right here, low PLGF, very low PLGF, the red bars, you see the delivery within the next couple of days or week or in the last 2 weeks. But when you look at the blue bars, which is the high PLGF, so normal placental function, most of these patients will deliver after 2 weeks. So it rules out disease within the 2 weeks of testing with quite like high confidence. And on the right here, we can see that independent of regardless of the diagnosis, so if it was low PLGF with preeclampsia or no preeclampsia, the delivery was estimated high for patients with low PLGF and no delivery for patients with high PLGF. It's just showing the power of ruling out the need for delivery within the next 2 weeks for patients with high PLGF and normal placental function. So when you bring like all this data into real life situations, we have this excellent paper from the Toronto group, Dr. Kindon, Kelsey McLaughlin, Dr. Jones, Snellgrove. They did a randomized control setting. They did an observational study that intended to check how does PLGF actually predict preterm birth for placental insufficiency. And then you can see the top line is the normal PLGF, so normal placental function, and the blue line, low PLGF, and the correlation with time to delivery in weeks in the x-axis here. So the low PLGF in pregnant women was associated with a significantly higher rates of preterm birth, as 40% of women with low PLGF deliver within the first 2 weeks compared to 1% of women with normal PLGF. And still, on the 4-week mark, 63% of women with low PLGF or very low PLGF delivered versus 1% of women with normal PLGF. They also reported the correlation of PLGF levels and mode of delivery, which was quite interesting, showing here the red lines. The delivery was way earlier, so more correlation with preterm delivery and C-section as mode of delivery, while the blue lines that show normal PLGF correlated with more term deliveries and inductions of labor and successful vaginal deliveries. Continuing with the work done by the Toronto group, you see here the placental pathology also correlates well with low levels of PLGF. In this publication, we see that there's a significant higher prevalence of maternal vascular malperfusion for patients that were found to have low PLGF. Remembering that maternal vascular malperfusion is directly linked to development of preeclampsia, preterm birth, IUGR, and stillbirth. So it's a powerful predictor of placental disease. So what does SOGC say about PLGF? Well, the most recent guideline on hypertensive disorders of pregnancy that was released 2022, it clearly mentions that to assess women with suspected preeclampsia, use angiogenic markers where available. So if you have PLGF, if you have the PLGF split ratio, use that. And moreover, SOGC guideline goes on and recommends that levels of PLGF or split PLGF ratio can accurately predict the development of severe preeclampsia and therefore the need to consider transfer to care to a regional center and the temporization for delivery. So I want to go back on our case to see if now we get an answer to those questions, because we were not sure if this patient just needed optimization of antihypertensives, if it's time for steroids yet, or if you need to transfer her to a level 3 center because delivery is imminent. But now you're practicing in Eastern Ontario and you just heard the good news that your center has PLGF and it's available, and PLGF is 14, which is very low. So what do you do now? Does it give you a little bit of a more prediction on when things are going to happen and how to go from now? All right, so I guess that yes, that patient's quite critical and need to transfer, and she needs temporization because delivery might be happening in the next couple of weeks. So based on robust evidence, we believe that PLGF is a reliable tool to predict preeclampsia and also timing of delivery. And therefore, we gathered the main specialists in each province in Canada and created a PLGF consortium. This consortium met first time November 2024, and then in January, this year, and emphasized the need to ensure equitable implementation of PLGF testing, including considerations for approximately 20% of Canadian population that lives in rural, remote, and indigenous communities. Our group acknowledged also the significant barriers that hinder the accurate and timely diagnosis of preeclampsia in Canada, including geographic isolation, physician access, racial and ethnic disparities, and among others. Proudly, in TOH, we instituted PLGF in 2024. And why did we adopted PLGF? We were the second center in Canada to adopt. I said we all drank the Kool-Aid from Dr. Kingdom and we just went for it. And we did because we believed that it would help minimize the burden of suspected preeclampsia in triage, admissions, and patient anxiety. Because there's overwhelming evidence that it's a reliable tool of risk stratification for preeclampsia to either reassure patients and send them back to outpatient care when it's high, and when it's low, timely identify a patient that is at risk of preterm delivery and developing preeclampsia, and ultimately because our guidelines say so. So how did we do it? So we were in a very, I feel like we were in a very lucky position that TOH already had the advantage of having the Roche platform that runs PLGF testing available at our sites. We used it for COVID tests, so I guess I can say that's a gift from the pandemic. Let's see the silver lining on that. So because we already had the most expensive part of acquisition for PLGF, which is the Roche platform analyzer, in 2024, I put in a health technology request by showing pretty convincing data that this is a reliable screening tool that can be quite cost effective, especially if it's justified by its high negative predictive value and the cost savings from discharging patients back to outpatient care and not admitting them for increased surveillance, unnecessary admissions, and costs related to that. So we secured 1,000 PLGF tests to pilot at a cost of 100 tests per test, including lab fees. And we chose not to adopt the S-split ratio basically because of incremental costs that S-split PLGF ratio would represent to our lab. And since PLGF also in isolation, as I just showed, predicts so well and rules out preeclampsia with a high negative predictive value, as I just showed in the evidence here, and through also Mount Sinai's experience, as I said, with Dr. Kingdom's group had come and nice, just like in a very kind way, helped us believe that this was the most suitable option in our context. Our tests are available at both campuses with a turnaround time of 2 to 4 hours for routine testing and 1 to 2 hours for stat requests. And it is proven to be a valuable tool in outpatient clinics and in our OB triage as well. So how do we use it? So any singleton pregnancy that we suspect preeclampsia, but it's not diagnosed yet, is eligible to have PLGF testing. At any time from 20 to 36 weeks, because we don't do universal preeclampsia screening at TOH. Why? To rule out PIH or to rule it in, and to aid us into decision making regarding maternal and fetal monitoring, like inpatients versus outpatient. And most importantly, especially for MFM cases, distinguish cases with baseline proteinuria and increasing BP levels or derangements in proteinuria as well, such as patients with CKD secondary to chronic hypertension, type 2 diabetes, type 1 diabetes, lupus, and so on and so forth. So PLGF is a great tool to distinguish when you have derangements on those labs and hypertension, if this is superimposed preeclampsia or this is just like worsening of kidney function with worsening proteinuria. And how do we do it? So we request it once in triage with our first PIH blood work. The patient with preeclampsia comes in, we request PIH blood work plus PLGF, and we will follow algorithms that I'll show it to you. But there's no need to trend or to repeat PLGF in the first couple of days, neither in the first couple of weeks, because as I showed to you, the curve of physiological increase of PLGF is very slow. You wouldn't see any changes even if you repeat it every day. So if there's a significant clinical change within the next 2 to 4 weeks, we would then trend PLGF if you already don't have the diagnosis of preeclampsia. So very cost-effective tool in triage. This is the infographic that we have in our triage just to remind people to request PLGF. And I also want to remind people when not to request PLGF. So never for multiple pregnancies because we don't have normograms for PLGF alone. I hear that there are some groups that are developing normograms for a split PLGF ratio, but not for PLGF alone. We don't know what would be the normal values for that. Never outside the period of 20 to 36 weeks. Definitely not after 36 weeks because the interpretability is not good for PLGF and prediction of preeclampsia. Definitely not when preeclampsia is already diagnosed. PLGF adds nothing when you already have diagnosis of preeclampsia, so no need to trend or repeat that after it's done. And not before 2 weeks for the reasons I explained for the physiological changes of PLGF. Also in 2025, our Quebec colleagues, Dr. Isabelle Mallamé, published this excellent paper with a proposal on how to use PLGF, advocating for it to be standard practice across their province. They proposed the same criteria I just mentioned for utilization, but most importantly, they mentioned that no clinical decision should be made based on PLGF alone, but interpreted in conjunction with clinical findings. This is how PLGF looks in our system. So we have it embedded in Epic, which facilitates our lives a lot. You can order it stat or routine. We usually do routine. And then when results come, you just hover over this number, and then you're going to have the reference values by centiles per gestational age that was extracted from the publication from the Toronto group. So this is normograms that are based on a population level study. And we chose to use the centiles per gestational age because that's what the Roche platform actually gives us, and not the exact cutoffs that are seen in RCTs. I feel like the cutoffs of 100, more or less than 100 for PLGF cutoffs, were used with another platform called Quidel. It's a point of care PLGF testing and doesn't reproduce much. It's similar, but doesn't reproduce much, such as the centiles per gestational age. And we just wanted to speak the same language as our colleagues in Toronto, as we were basically adopting the same guidelines and directives. They had used this for 4 years. So we just wanted to adopt the same normograms as well to speak the same language across sites. So the red columns, the less than 5 and the less than 2.5 centile, is the low and very low PLGF. And you can actually see that the cutoff of 100 or less corresponds to the less than the 2.5 centile, sort of, depending on the gestation. You see the peak around 26 to 32 weeks, but just as a rule of thumb, if it's less than 100, it's a very low PLGF, and you should be really careful with this patient and monitor mom and baby. If it's more than the 10th centile, it's normal. Definitely if it's more than the 50th centile, it's very normal, and you can be reassured this patient is not going to develop preeclampsia or deliver within the next 2 weeks. And if it's between 5 and 10th, it's the gray zone, the yellow column there, that we need to be a little bit more careful with the clinical presentation and make sure that if there is a critical change, that PLGF is trending within the 2 to 4 weeks. This is just a summary. So anything that is red, less than the 5th centile, highly abnormal. Anything that is more than 10 or more than the 15th centile, very normal, suggestive of normal placental function. And this we adapted from the proposed management from the PAIR trial by incorporating lessons that we learned during our first year of using PLGF at TOH. During our implementation, we tried to use the PAIR trial, but given resources at a tertiary care center are quite scarce and we couldn't attend to the highly intensive surveillance that PAIR did for being an RCT in a controlled situation across campuses, we just adapted and proposed the management and surveillance depending on PLGF level and depending on blood pressure at presentation. If PLGF is low and the patient is, or if the patient is clinically unstable, this would mean intensifying surveillance, admitting, or maybe doing closer follow-up in clinic, maybe once, twice a week. But if the PLGF is normal and the patient is stable and the baby's fine, then you can discharge to follow outpatient care if no immediate concerns. Worth to mention that every center in Canada who's adopted PLGF, we have about 4 or 5 centers now that have adopted PLGF, they all have their sort of their own protocol, as there's not yet national guidance from SOGC on how to interpret PLGF in view of our guidelines. It's not embedded there. So we're sort of like learning as we go. And we have not validated this algorithm, so please don't reproduce or don't take pictures. Like, it's good to know, but most importantly of all, like, PLGF should be used in isolation. It should never be interpreted just in view of your blood pressure, but in view of your whole clinical case. And that's the lesson that is most important to be sent across the board today. So in summary, PLGF is an excellent risk stratification tool to be used in triage outpatient clinics. And basically, it works as you see here. A patient comes in with a singleton pregnancy between 20 and 36 weeks. You suspect preeclampsia, you do the PAH blood work and the PLGF testing. If PLGF is high, there's a low likelihood of developing preeclampsia. Patient can go to antenatal care, routine antenatal care as an outpatient. But if your PLGF is low, you should sound their bells and alarms, because this patient has high likelihood of developing preeclampsia within the next 2 weeks. So she needs close monitoring and step-up care. I feel like at this point, PLGF in a nutshell is in this slide, and I hope that my colleagues practicing at a level 1 or 2 center can appreciate the value of this screening tool to bring to your practice. So we'll stop again for another clinical case. So this patient's not as sick. She's 38 weeks, she's G1, 33 weeks. She has low risk antenatal care. She presents to your triage or maybe your outpatient clinic with a blood pressure above 145/78. She has a bit of a headache. She has no visual changes. She attributes it to the fact that she didn't sleep well last night. The last ultrasound at 30 weeks showed the baby's got normal growth of 45th centile, the NST normal. You have no ultrasound available to check for growth today or Dopplers, but the urine dipstick shows a PCR of 1 plus. You do the PIH blood work, and your CBC, LFTs, and creatinine are all normal. So if this patient arrives to my clinic today, I ask myself some questions. I hope you ask yourself too. So, is she developing preeclampsia, or is this just gestational hypertension, or is this just a one-off because she didn't sleep well? And if it is gestational hypertension, will this turn into preeclampsia, and how soon would it happen? Should we expect delivery anytime soon within the next couple of weeks? Or if we are thinking about delivery because she's getting severe preeclampsia, should we give her steroids now? And should we admit for antihypertensive therapy and close surveillance? Or should we just give her maybe Adalat, give her labetalol, maybe send her home, bring her back in a week? Like, what is the safe thing to do here? Which is pretty hard to judge if you only have a PCR that is 1 plus and normal NST, normal CBC, LFTs in urea, which is most of the times what happens. But if you do PLGF and it's 450, which is really high and normal, reflecting normal placental function, maybe you can reassure this patient. Maybe you can treat her. Maybe you need to give her antihypertensives, but you can say, you don't need admission. You don't need steroids. You're not delivering in the next couple of weeks. You can be sent home. I'll see you again in 1, 2 weeks and follow up with, regular antenatal care. So that's the value right there. She does not need to be transferred to a level 3 center. She does not need steroids right now because you're reassuring her placental function is normal. We learned a few lessons while using PLGF between 2024 and 2025, and I just wanted to quickly share them with you. Based also on studies that we found, we just trying to measure a few variables, and we saw that the PLGF at our center showed exceptional negative predictive value. No patients with normal PLGF actually develop preeclampsia, and most of them deliver at term, except for 2 patients who PPROM'd at 35 weeks. PLGF actually changes and shows that it's abnormal way before than other markers such as PCR and fetal Dopplers, predicting with accuracy delivery within the next 2 to 4 weeks when it's found to be low or very low. On the other hand, when we had high PLGF, most patients delivered at term, and most patients with normal PLGF on the green bar delivered by vaginal delivery, while C-sections were well correlated with patients who had low PLGF. It's essential for medical complex cases such as the ones I mentioned, when you have baseline proteinuria, either because of chronic hypertension, lupus, diabetes, all my patients with type 1 diabetes and baseline proteinuria. PLGF is the most reliable tool to rule out superimposed preeclampsia when you have changes in those markers with accuracy. And clinical status still drives delivery decisions. So PLGF is a great stratification for risk of preeclampsia, but maternal and fetal clinical status remains the primary guide for steroids and delivery. We should not base our decision for delivery or mode of delivery or timing of delivery based on PLGF. Steroids, I think there's advantage of deciding steroids based on your PLGF levels, but definitely not the timing of delivery. We still follow SOGC guidelines with the amazing tables that they have for IUGR and for preeclampsia management and timing for delivery. And like I mentioned, strong correlation with placental pathology. So for very low PLGF, we looked at our placental pathologies and we found that most of them had some sort of disease, but maternal vascular malperfusion being the most prevalent, showing that our experience of, although very short with a very small sample size, reproduces the findings that we saw in the literature. I truly believe that we're moving towards a new era of placental disease diagnosis. And at this point, during this presentation, I hope we all understand that preeclampsia is a placental disease that can be expressed by angiogenic imbalance, and that starts early in the first trimester and could predict pregnancy outcomes. I hope that the audience can appreciate the value of PLGF in the second and third trimesters and the power of predictability of preeclampsia and preterm delivery within 2 to 4 weeks of testing, identifying patients who are at risk, proposing increased surveillance while reassuring patients with normal PLGF. And as we move on from implementation, piloting it at TOH to dissemination, I'm happy to share with you that the plan is to have PLGF ready for use in every Aurora TOH partner across our region. The plan will be for disseminating this in a stepwise approach with support from our lab stakeholders and CMNRP leadership. For the non-Aurora TOH partners, I know that PLGF is available through shipping to Mount Sinai. You just need to have a conversation with them. But for now, Kingston and the Trillium Health partners do ship it, as Regina actually used to ship to Mount Sinai and just recently adopted the point of care Quidel assay because it was much cheaper than shipping to Mount Sinai. So they adopted their own. So they're definitely open to a conversation as we are. But for now, we will focus on the implementation at PLGF at our region through the Arola labs. And these are the turnaround times that you should expect at your center when we roll it out. So it depends basically where you are in the region and the distance from the civic campus. So this is the routine turnaround times that, although you can think like 6 to 8 hours is a lot, stat times chops off some of, couple hours from that and can be really important in trying to optimize costs of transportation and allocate resources when this patient needs to come or not to another level for care. So really hopeful that everyone is excited about it, and stay tuned for more PLGF news to come because your center might be the next. I won't say which one's the next, but we're planning on it. I want to thank everyone, but most especially my early lab support, Dr. Dan Lin, the head of Biochem, who helped us to validate and roll out the PLGF at TOH at both sites and keeps being such a my right hand at this process of making sure that PLGF reaches the other regional centers in the next year. Definitely the division and department heads, Dr. Singh and Dr. Moretti, for their support with the health technology assessment and the dissemination of this tool within our 2 campuses. And the CMNRP leadership, Darlene and Lauren, thank you so much for the invitation. I'm truly honored. Please, everyone, this is my email. And if you have Epic, you can chat, use the chat or the staff message to reach out to me. Consult me if you need to use PLGF and you don't know how, please reach out. And if you want to dig a little deeper on the literature that I just presented today, I have this QR code that takes you to a PLGF link tree. I really appreciate everyone staying at 7 p.m. on any given Tuesday to listen to PLGF news. It's truly honoring and humbling to be here. And I will take any questions that you may have. Thank you so much.
Oh, sorry. Excellent. So thank you so much, Dr. Werlang. We really appreciate such an insightful talk. And I think you've done such a great job of demonstrating how valuable it is in terms of using it as a predictive tool to allow for decision making that can get patients to the right place for the right care at the right time. There are some questions that are in the question and answer. The first question I believe we have answered live, which is in relation to how quickly do you anticipate the results of the test for its use here. The participant is anonymous, so I don't know what center they're in. So I'm going to say that we've answered that. If we did not, please go ahead and put in an additional question. Our second question is, do you send your PLGF immediately with all of the other preeclampsia labs, or only if your diagnosis is unclear based on the result of your labs?
That's a great question. Because it takes 2 to 4 hours to get PLGF back, I think there's value in sending with your first set of blood work when you suspect preeclampsia. So if a patient presents and I feel like maybe this is preeclampsia, I don't know what it is. Sometimes the nurses actually do the dipstick and it's like 3+. I'm like, well, this is probably preeclampsia. But if it's 1 or 2, I still send it. I still send it because of the predictability. If it's like really high or really low, it gives me an idea of when the patient might deliver and if she needs closer surveillance. It guides my practice. So yes, with the first set of blood work. Now, if you keep repeating the PIH blood work as we usually do every 6 hours, every day, don't repeat PLGF. It's not going to add anything to you, to your management. So the answer is yes with your first set of blood work.
Excellent. Thank you. Okay, so our last question that is in the chat is there any chance to get, oh, and we've got other questions popping up, which is wonderful. Is there any chance of getting PLGF testing done in southwestern Ontario, so London or elsewhere? And I appreciate you might not know the answer to that one.
So I don't know, but what I know is that we can start conversations with stakeholders at Mount Sinai. Like I mentioned, like Trillium sends the blood there, Kingston sends the blood there, Regina used to send it. So there might be opportunity for some collaboration between your lab and Mount Sinai's lab. I can offer collaboration from your Orla right now. I didn't mention it in the presentation, but it's just all about budget, right? This is not provincial budget. This is hospital budget. So it needs to have like conversations need to happen before we can start running PLGF. I would love to, but we need to conversations to happen before we can offer to other partners. So Mount Sinai, I
Yeah,
think would be also I should say maybe you want to start conversations in London, Ontario, because Dr. Banner, Harrison Banner implemented that as well. They have a split PLGF ratio.
excellent. And I was going to suggest looking into even whether or not your lab had the capacity based on whether you brought in the right, and I'm going to use, I've forgotten the name of the testing company, but the,
Yes, either you have Roche or if you have the
yes,
Quidel. So if you
yeah,
have the Roche, that's like a million steps ahead to implement this because that's
yeah,
what's expensive. It's the platform. Yeah.
excellent. And then the last question I think you've already answered as well, but is it a publicly funded test?
Unfortunately, not yet, but that's the push we're pushing for it because we feel like for PLGF to be equitable and access to be available at every center, it needs to be a provincial funding. But there's moves around how we can make it provincially funded. So just stay tuned. Hopefully. Yeah.
Excellent. So there are no other questions. So I'm going to thank you again for such an incredible talk. And I'm going to invite everyone who is online with us to reach out if they do have additional questions. We're also going to put a link to our evaluation into the chat for you to access. So your feedback is really important to us and it will help guide us on future CMNRP regional ground rounds as well. And then finally, want to say one more big thank you to everyone for joining us tonight, to Dr. Werlang for such an insightful conversation and presentation, Charlotte Maloney from CMNRP for all her work in the background. And a reminder that the video recording will be sent out to all of the registrants, and it will end up being posted on the CMNRP web page, which will link to the YouTube channel. So thank you so much, everybody, for joining us.
It's a pleasure. Thank you so much.
Excellent. Have a wonderful evening, and we look forward to sending out communications about our next regional grand rounds in the near future.
Thanks. Have a good
Thank you,
night, everyone.
everybody.
Thank you, Charlotte. Bye.